Good day. My name is Marvin Moreno, and today the topic of my presentation will be about the symptomatology presented with dilated perivascular spaces in mild traumatic brain injury. Traumatic brain injury may result from anywhere between a simple blow to the head to a penetrating injury to the brain. In the United States, around 1.7 million people suffer TBI, with older adolescents and older adults among the most likely to sustain a TBI. TBI has been categorized as mild, moderate, and severe TBI, with mild TBI or MTBI comprising most of these cases. MTBI, also known as concussion, initially considered as a benign event and has attracted tremendous attention for some of its adverse neuropsychological outcomes in civilians, including athletes who play contact sports, as well as military personnel. MTBI commonly presents as a confusion or change in consciousness for less than 30 minutes or transient neurological changes such as seizures, headaches, or cognitive changes. Many studies have been conducted to identify trends in MTBI. DPVS is one of them. Also known as Virchow-Robin spaces, DPVS are spaces surrounding the walls of arteries, arterioles, veins, and venules as they course the subarachnoid space through the brain parenchyma. These spaces do not communicate directly with the subarachnoid space, but they are filled with interstitial fluid and cerebrospinal fluid. Dilated perivascular spaces consist of regular cavities containing an artery, and they can become abnormally enlarged or dilated and in even some cases cause hydrocephalus. The mechanism of how this occurs is not well known, but it has been proposed that the inflammation consequent from MTBI could cause the formation of DPVS. Identification of DPVS on neuroimaging has been investigated as a potential biomarker after the occurrence of MTBI. The drawing on the left shows a cortical artery with a surrounding dilated perivascular space crossing from the subarachnoid and subpial spaces through the brain parenchyma. The magnified view on the middle shows the anatomic relationship between the artery, dilated perivascular space, subpial space, and the brain parenchyma. The rightmost image is a histological slice of a coronal section of the brain parenchyma with two penetrating arteries as indicated by the straight arrows. Immediately around these arteries is a clear area indicated by the curved arrows. These are areas of significant cerebrospinal and interstitial fluid accumulation, also known as dilated perivascular spaces. The aim of this study is to investigate the relationship between the number of dilated perivascular spaces with symptom presentation and longevity in patients diagnosed with mild traumatic brain injury. A total of 188 patients were included in our study. These are individuals that met our set of inclusion criteria and was diagnosed with MTBI by a board-certified neurologist. The average age of our participants is 41 years old, with a range from 14 to 82 years old. Approximately 55% of them are female. The primary source of MTBI on our sample set is motor vehicle accident, with 72% of them experiencing loss of consciousness during the inciting event. Regarding our procedures and methods, we first conducted a retrospective chart review while gathering information including demographics, details about the event that caused the MTBI, and the associated symptoms. The primary symptoms we focus on are headaches, balance deficits, cognitive complaints, fatigue, anxiety, depression, and emotional lability. We also acquired MRI images using the 3.0 Tesla MR Signa HDXT system. Using the imaging protocol, T1, T2, and FLAIR sequences in axial and sagittal planes were acquired and were interpreted by a radiologist. For the identification of DPVS, the very first steps involved going through the T2 axial scans and noting hyperintensities within the centrum semio valley, basal ganglia, hippocampus, and also the midbrain. Looking at the image on the right-hand side, the areas of increased signals encircled with the green are the dilated perivascular spaces. The periphery of the hyperintensity encircled in red is from a lacunar infarct, while the middle is a dilated perivascular space. After the hyperintensities were identified using the T2 axial sequences, these are cross-referenced with either a T1 or FLAIR sequences. To be considered as DPVS, the hyperintensity identified in the T2 axial slices must be hypointense in the FLAIR or T1 axial sequence. Focusing on the image, hyperintensities can be identified in the T2 image and become hypointense as indicated by the red curved arrow using the FLAIR modality, while the peripheral hyperintensity from the lacunar infarct can still be observed. Additionally, the diameter of the DPVS must also be greater than 1 millimeter. Once considered as DPVS, they are classified as Grade 1 or Grade 2 DPVS. Grade 1 measures from 1 millimeter to less than 3 millimeters, while lesions greater than or equal to 3 millimeters are considered as Grade 2 DPVS. After data collection, statistical analysis was performed on the number of DPVS and symptom improvement using a right-censored, log-transformed parametric regression model. These images are examples of enlarged perivascular spaces in different brain regions. These are T2 contrast MRI images in the axial view. DPVS are encircled in green. From left to right, we can see the presence of DPVS in the midbrain, hippocampus, basal ganglia, and centrum semiovale. For our results, the table present in the current slide shows the association between the number of DPVS in specific region and the frequency of symptom presentation of interest. We have found that a higher number of grade 1 DPVS in the midbrain area is associated with increased frequency of presentation of anxiety and fatigue with a p-value of 0.016 and 0.00024 respectively. This table shows the association between the number of grade 1 dilated perivascular spaces in certain brain regions and its relationship to increased time to improvement of symptoms. From our data, we found that there is an increased time to improvement of depression with patients presenting with higher number of grade 1 DPVS in the midbrain and basal ganglia with p-value of 0.0499 and 0.03 respectively. Also, a higher number of grade 1 hippocampal lesions was also associated with increased time to improvement of post-concussive fatigue with a p-value of 0.034. Lastly, a higher number of total grade 1 DPVS lesions was associated with increased time to improvement of post-concussive depression with a p-value of 0.035. In all of the aforementioned cases, the covariates age, gender, and loss of consciousness were not significantly associated with time to improvement of post-concussive symptomatology. To conclude, these results contribute to the existing literature describing DPVS as a potential viable quantitative biomarker for MTBI. Our results are consistent with the previously published analysis by Inglis et al. Reporting unremarkable differences in cognitive testing between DPVS positive MTBI patients compared to the controls. To our knowledge, this analysis is the first to describe a statistical association between the number of DPVS and longevity of post-concussive symptomatology. Thank you.